Good afternoon. No problem. Good afternoon. It's good to be here with everybody today. We are at Tech's Role in Equity and Value-Based Care. I am pleased to be joined by two wonderful panelists. First, my name is Matt Sobolski. I'm a founder of a company called Ionian, and I do work in go-to-market and healthcare tech and been after it for quite a while. A few years ago, I published a book on interviews of people working in digital health and tech and getting their ideas on sort of like the social influence and the meaning behind what they build. So I was really honored to be asked to come speak today and moderate this panel. First of all, happy International Women's Day. Yeah, it's fantastic. Yes, it's wonderful to be a part of that. I have something that I learned over the years speaking to leaders, and that is community is success. And when you think about value-based care and you think about health equity, you think about building communities, not just outcomes. Today reminded me of that mantra that I had learned from others working and building these tools. Diane Ackerman wrote a really good book called The Human Age. In that book, she talks about how technology over time isn't going to separate us, but actually gets us closer together and makes us more human. What better way to think about getting closer to humanity than building tools that are health focused on equity and fairness and justice and outcomes? Carl Sagan also said, as technology continues to grow, we have to use our imaginations to make things better over time, which is really our responsibility. It's not just enough to talk about the technology we have, but it really is a lot to talk about what we can do as humans to make things better over time on this planet. A couple facts and figures that are interesting to me. By 2027, 160 million people in this country will be under a value-based care plan. That's a $1.7 trillion market. Most of that spending looks like, through some research, to be on healthcare improvement technologies. 1 in 5 Americans have a mental illness that's considered problematic. A lot of those 20% of people also have trouble reaching care and access, a massive problem in the United States. And research over the last 5 to 6 years have pointed to something very important, which is trust. If you think about health equity, you think about the history of the United States, you think about what we've fumbled and what we've won when it comes to healthcare, and trust is a problem. But there's lots of research empirically showing us that when you focus on trust, you focus on outcomes, you focus on adherence to medications, and people improve. Welcome. Our panelists, please introduce yourselves and tell us what organization you're with, and then I'll move on to the next questions.
Hi, my name is Michelle Nichols. I'm a family physician, and I am from Meharry Medical College, where I'm the Senior Vice President for Clinical Affairs, and I'm also the designated institutional official over all of our residency training programs. I'm very excited to be here. Thank you.
Good afternoon, everyone. Naseem Afsar. I am the Chief Health Officer at Oracle Health. I am an internal medicine physician by training and background. Spent about 15 years on the healthcare delivery side, and then the last 2+ years with Oracle Health.
Michelle and Naseem, it's good to be here with both of you. Let's start with a question. Let's get the conversation going. Naseem, I'll start with you. Set some tone for us. What is health equity, and why is this an important topic for you personally in your leadership?
Yeah, Matt, we talk a lot about health equity, and health equity means lots of different things to different people. I like to think about it really simply, which is health equity is health. What do I mean by that? We can't achieve true health unless we are addressing and promoting the disparities in healthcare that we have. So health equity is health. Now, on sitting here on International Women's Day with all of you here in Austin, I have to acknowledge the fact that it is absolutely unacceptable that we have increasing trends in maternal mortality over the last 2 decades, with particular populations like Black, Alaskan populations, American Indians, with even higher than twice the mortality rate. At a time where we perform miracles in maternal and fetal care, where we can go in utero, if a fetus has a defect, we can go and do in utero surgery to save the life of the fetus and the mom. We have women who are dying in this country for something that is biologically essential and absolutely basic, which is childbirth. So I go back to health equity is ultimately health.
Yeah, health equity is health. Michelle, some commentary on that.
So, in order to understand what it means to me, I like to give you a little bit of my history. I'm from Mississippi. So, I went to school at the University of Mississippi, also known as Ole Miss. 3% of my class, there was only 3 blacks, people of color in my class, in my medical school class. And I came from a background where the social determinants of health were very common. I looked at food deserts were present. Health equities were present. I lost family members because of that. So as I went on to train from there, then I went to Duke, I happened to meet Dr. Lewis Sullivan. So for those of you who don't know him, Lewis Sullivan was the Secretary of HSS, of Health and Human Services. And he was the first African American that ever spoke at my graduation class at the University of Mississippi. And then I met him again later. And he said, how would you like to come to Morehouse School of Medicine? So that was my first experience of being at a historically Black college and university where I wasn't the minority anymore. So it was a different experience, but I thought about this gives me the opportunity to give back and to pay it forward with health equity. So what is health equity to me? Health equity is providing people with what they need in the amount that they need it so that they can get their optimal level of health. So by that, there's a difference. People think health equity and equality are the same, and they're not the same. So when we say equal, let me use an example. I'm relatively tall. So let's say there was a wall that was 6 feet tall, and we gave everyone a box that was only 6 inches tall. So I can stand on that 6-inch box, and I can see over it because I'll be above 6 feet. Whereas if someone else, like my younger sister, who is 5'3", if she stood on that box, then she would not see anything because it's only 6 inches. So it's equal, but it's not helping her. I'm going to be really high. Whereas if someone like my son, he stand on that 6 feet box, that 6-inch box. He would be very tall above that box. And so therefore he really didn't need that box. I didn't need that box. My sister probably needed 2, maybe 3 of those boxes to get. So that's being equal. So we're saying that we're talking about equity. So we want to give people what they need. Some people might need 1 box, some people might need 2, some might need 3. And so that's where I think about what health equity is.
Thank you, Michelle. I want to continue with you. Health disparities in technology. How can we use technology to address disparities and access in your mind?
So one of the things we can use for technology, so we can go back to the pandemic. So the pandemic made us, it just really exacerbated and allowed us to see what was true health inequity. So one of the things that happened, and I look at my own patients, we quickly, like everyone else, we quickly pivoted to telehealth. It was great. But what do you do when your patients they don't have broadband? What do you do when they don't have a phone? All they have is a landline. What do you do when they don't even know how to use technology? I have a lot of older patients. So what do you do in those? So that's where it's helpful to say, and then people start saying, what can we do to bridge that gap? So we started saying we need to give people probably mobile devices. We do remote services. So, like the smartwatch or something like that, so you can connect. So that's where technology. And then when you go to AI, so I really am excited about the potential with AI. But when you look at AI, I always look at it like a double-edged sword. You have to make sure that you monitor it and control it because it's a great tool, but you want to make sure that it is a tool that is going to be beneficial and you don't want to expand that gap that you can see from technology. And so that's why I say it's wonderful. I think technology is wonderful, but it also can either open the gap and make it larger, or technology can close the gap.
Yeah, I want to add on to that. Those are such great examples of how we can both help people, and then the flip side, Michelle, I think, where we have to really balance and be thoughtful. And I wanted to add another example because I think this is the strength of coming to meetings like this where we get to have shared learning around what's out there, what's working, what's not. One of the ways that we've leveraged technology effectively is to partner with delivery systems when they have particular populations of patients that they're particular vulnerable populations of patients that they want to help advance. So in a community in the UK, there was a healthcare delivery system that realized that in a vulnerable community, the rate of diabetes and hypertension was increasing in that population. So leveraging technology and geolocation, they were able to see that they actually were aggregated around a local community church where a lot of those members attended. And then we were able to partner with the church leadership, the delivery system, as well as Oracle Health to be able to have screening and visits in that community so that we could address hypertension and diabetes, and we got improved results in the performance for those two chronic conditions. So I think, again, lots of opportunities where one can leverage technology to lift populations, but to Michelle's point, and I do want to emphasize it, we have to be very thoughtful about when and where we are doing that.
Nassim, let's follow on that. Earlier today, you and I had a conversation, and you reminded me of something you called the 80% rule. Tell us about that and how it impacts social determinants and also health equity.
Yeah, so this is what I call the 80% problem, which is 20% of what determines someone's health is what happens within the four walls of a healthcare delivery system. 80% of what determines their health is where they live, where they work, their genetics, their habits. The challenge with that is that we have tried to address health and care by focusing on the 20%. And then we wonder why we sit here in 2024 and we've had continually worse performance in health outcomes, why we have continued increasing costs of care. For us to truly address healthcare, we really have to bring that 100% of what it takes to care for the patient. We have to bring the 20% together with the 80%. So we have a health data intelligence platform that brings in data from thousands of sources, aggregates it, connects it, and then applies analytics to it so you can have intelligence. And one of the cases I love about this was that a patient with heart failure, which is a chronic dysfunction of the heart, that was continually being hospitalized and continually getting medical care. Through this process, the team was able to realize that it really wasn't about the clinical condition and the fact that he needed more medical care. It was about the fact that he had food insecurity, that he was buying food on sale, which is oftentimes cans that are high in sodium, kind of the worst food that you can have if you want to decrease the load on your heart. And so through that, they were able to connect him to community resources for food as opposed to continue to treat him medically and really fail on ensuring better health for him.
Michelle, comment.
That's a really great point that Nassim brought up. I applied for a grant, and one of the things that we did was to look at that also. So everyone, well, not everyone, but people have heard of the patient-centered medical home. That's where you have the patient in the center, and you of the home. So we decided to look at, and this is when I was in Atlanta, at a community medical home. And so one of the things when you look at that is you go to the person, you go to their home. And we empowered them because we were looking at a population that had a lot of social determinants. So one of the things that we did was we gave them an iPad. So we got an iPad. We took and trained if they were a person that had heart failure, for instance, and they had grandchildren or someone in the house. We trained them to be community health workers. We actually set that program where we certified them. So we started a program where we would certify high school kids so that they could they'll have jobs later when they finished high school. But what it did was, and we monitored everything, and the family member became the one that will help to their grandmother who might have heart failure. So that's what it says. We spend so much of our resources on that small 20%. So what we really need is to open it up and give them the tools so that they can improve their quality of life.
Thank you. One thing that we've been talking about quite a bit is about community, and healing does not happen alone. Naseem, when we talk about health disparities, we talk about value-based care, you can't do it by yourself. You have to have tools, you have to have support, you have to have a fabric of products, people, and communities, and the patient. What are your thoughts on partnership when it comes to succeeding in achieving true health equity?
Yeah, great question, Matt. So, this may be controversial as I'm coming to this from a healthcare technology standpoint, but technology isn't going to solve our healthcare problems, right? Technology is a tool. It's an incredibly powerful tool, but what unleashes the ability of technology to improve healthcare is partnerships, and that includes everyone in the healthcare ecosystem. So that includes the patient, first and foremost. It includes our payer partners, retail, food and beverage, life sciences and discovery. And I'll give you a couple of examples of this and why this is so critical. So I was having a fascinating conversation with a health executive for a major food and beverage company in the US. And they were sharing with me very enthusiastically about how they are helping advance better health and care. And they shared with me that based on buying habits of their consumers, they've put them in three categories, from super healthy people who buy fresh foods and vegetables and have lean proteins to unhealthy people with unhealthy habits, people who are consuming a lot of processed foods. And so what they would do is that if you then came to shop online and you were in the unhealthy category and you went to put the potato chips in your cart, you would get a decision support that would say, hey, what about the baked potato chips, which is kind of the middle category, or what about a potato, which is a healthy category? So they were really trying to do their part to help the consumer make better decisions. Really great intentions. Here's the problem. There was someone at our table who said, well, that doesn't make sense to me because I buy all my junk food for the household from your grocery store. I buy my fresh fruits and vegetables at the farmer's market, and I get my meats at another chain. So from your perspective, you are providing me messaging and decision support that doesn't really fit what my needs are. And that's why I throw away what you send me or ignore it. No matter how good our intentions are as individual organizations, unless we come together and partner, we are not going to be able to move things forward. Here's an example of where a partnership does move things forward. So we have a partnership of over 100 delivery systems across the globe, mostly US-based, but some international, They have come together and have over 100 million patients and have come together with the sole purpose of how can we help advance the care of this population, leveraging this data together. With Oracle Health, we're able to proactively identify patients who could benefit from clinical trials. So new discoveries that come to market. Now, having trained and worked at an academic medical center for 15 years, I can tell you we had people who traveled from all over the world to come and get world-class therapies. But not everyone has access to that. In fact, the majority of the population in this country don't live close to an academic medical center where they would have access to novel therapies. We actually have in that database a large representation of rural hospitals and critical access hospitals. So guess what? We now have 3x the amount of diversity in clinical trials enrollment and being able to provide these novel therapies than national clinical trials. So again, there are opportunities to be able to come together thoughtfully in partnership to look at how do we close that gap. If we don't do it thoughtfully, and again, I'm going to keep going back to this because it's the other side of the coin, is what Michelle was saying, technology can exacerbate disparities, but there's such tremendous opportunity to take that powerful tool, partner, and be able to advance and improve the health and care of individuals and populations.
Thank you, Nassim. Michelle.
So I'm going to take what Nassim just said and look at it on the side of value-based care. So one of the things when you looked at he just said there's going to be $1.7 trillion that we're looking at in just 3 years from now. So if you look at value-based care, it was how do you take and try to control those dollars so that everyone can get equitable services. So one of the things that CMS did, probably now is close to 20 years when it was recommended, we really started implementing was risk adjustments. So when you look at how people are risk adjusted, that made a huge difference in my opinion, particularly for my patients. So when I looked at my reimbursement, the payer mix, my reimbursement from CMS, I can now say that all of my patients that had hypertension, diabetes, hyperlipidemia, the list goes on and on and on with their chronic diseases. But that when you risk adjust them, they're going to have more than their level of risk are greater. And so that the people that were impacted were those people with health disparities. Classic example, if you're looking at the same amount of dollars, and I'm going to use New York, for example. And I'm not from New York, so I might be giving the wrong data, okay? So, but let's use Manhattan to Harlem, okay? So if you look at that someone might they can go to 3 different places for their fruits, for their junk food, for everywhere because they have all this access. Whereas another person, all you have is the corner store if you live in Harlem. So if you were to risk adjust someone that would probably lived in Manhattan that was worked on Wall Street or something, their score will be just normalized. It'll be normal. You won't see it. Plus, they'll be able to get the care that they need. Whereas you have the people that have all the social determinants, it's going to be high because they're eating unhealthy. They are eating chips because you get those from the corner store. They're eating canned goods because that's all that is affordable and they can use. They're eating different type of lunch meats because it's inexpensive and that's what they can afford. They're eating things that aren't healthy. Fruits and vegetables are very expensive. I think most people know that. It's very expensive. And so that's where the risk adjustments and value-based care, I think, can be really beneficial when you look at it from that standpoint. But once again, tools help you so much. And I think I'm really happy to hear what Nassim just described. And let's go to AI. I think that one of the things is that you can then take that data that you have of where all the places that people can go. You can partner with people in the community. They can pull that data, massive amounts of data, more than we could do or more than all the community health workers that we put out there. They can take that, pull it together, and then come up with a plan for the person. They then can say, this is how I can connect you to this organization, this organization, this organization, so that now you are able to come up with the better care for that person with people who do have those resources and want to. So I say, once again, technology can really, really make a difference, but you really do have to manage that technology.
Now, to both of you, let's continue with this conversation. Inclusivity, when it comes to AI and machine learning, there's bias in these models, right? There's some famous examples. Maternity care in the various platforms has great bias. Cost of care across the United States, for example, there's bias in the platforms. And then, of course, outcomes for health or exacerbation of disease based on the platform geographically across the world. How do we mitigate bias so that we can promote equity?
Yeah, Matt, it's absolutely critical that we are deliberate in the building, implementation, and continuous monitoring of AI and ML algorithms. To Michelle's point, there's tremendous potential in being able to leverage those to have insights about populations that we wouldn't otherwise have, right? We can leverage algorithms to be able to anticipate when someone is likely going to have food insecurity or housing insecurity and be able to be preventive. Everything we talk about is like we are trying to manage the problem after it's occurred. We are now in a world where we can actually be predictive and proactive in how care is delivered. But we can't be proactive, we can't be predictive and proactive unless we are absolutely deliberate in the design of algorithms. So the data sets that we use to make sure that we are creating the algorithms have to be inclusive. The implementation has to be thoughtfully done with training of people who use those algorithms so they understand both the strengths but also the shortfalls of the algorithm. And then there has to be continuous monitoring of these algorithms, right? And I kind of think about it like, when you go buy a new car and it runs perfectly, you don't assume that in 20 years, if you do nothing else, it's going to continue to run the same way, right? There's a lot of maintenance that you do. You do a lot of checks to make sure, oh, now the tires are worn out, the shock absorbers. I'm not a big car person, so I'm going to stop the analogy there. But you have to do that continuous monitoring to make sure that that car continues to run the same way. It's the same with algorithms because populations change, disease patterns change. So unless you're continually monitoring the output of the algorithm, you're not going to be able to know that something that was closing disparities of care 2 years ago is now actually exacerbating it.
Michelle.
So one of the things I've started experimenting a little bit with Chat GPT. So one of the things that, so if you were to say, please give me, please provide a photo of a doctor, and people have heard this before. That doctor is not going to look like me, and it's not going to look like Nassim either, because you didn't give it any parameters. You just said, please provide me a picture of a doctor. And so it's not going to look like us. And so that can be looked on as bias. Whereas I said, please provide me a picture of a female doctor who is also African American, and it will give me that. And so that's why you have to look at those types of how do you take to reduce bias? How do you go and put those parameters in or algorithms? So that's a really key point is how do you do that? Because technology and AI is wonderful, but you have to put guidelines in place. For example, one of the things in our legislature, our government, is actually looking at that right now. So one of the things is that there is the Bill of Rights, AI Bill of Rights. So that was the blueprint for that came out in 2022. And so in it, there's a lot of things that that document, it's like 5 points that they look at, and it talks about how to do safety, testing, privacy, all those things are included in that document. Fast forward 1 year later, technology is moving really, really fast. President Biden he released 4 months ago, October 30th, 2023, he released his executive order. And so it expanded on that from The 6 to now is 8. And so again, it's going into those things to make sure that you protect, because the goal of this is to protect us, to protect the Americans, or whatever country you're referring to. But in our case, it's how to protect us. If you listen to the State of the Union address last night, AI was mentioned twice. And so as I was thinking about this, I said, wow. So he actually brought it up in the State of the Union. So those are things that you want to look at as far as what the steps are needed. Now, if you want more information, you can go to whitehouse.gov, or or you could use whatever search engine you like to use. So I'm not going to name any particular search engine like I normally do. So whatever kind of search engine you like to use, you can just put Bill of Rights, AI Bill of Rights. You will get, that's technology. You will get a whole bunch of references to it. Or you can just say the executive order and you will get pages. I mean, it's much data if you want to. But I'm just saying that those are things that you want to think about as far as the protection, to eliminate bias, to make sure that we are protected and that our best interest is taken into account.
Michelle, just on generative AI. By the way, I love that you say please to ChatGPT, because that's what I do. And my younger kids reminded, they're like, why do you say please? We just ask it questions. It's not a person, you know. I'm like, I can't ask without saying please. So I love that you do that, and I know that I'm not alone. Um,
Yes, different generations. Yes, that's why our kids don't quite do things the same way, but that's a whole nother topic.
One of the things that's really critical about generative AI, and we were talking about this kind of ecosystem of healthcare, so I wanted to emphasize that, is that it does give us tremendous capacity to be able to take burden off of those caregivers who are taxed with doing lots of different things, including being really thoughtful about the kind of care that they deliver, right? There's not a single caregiver who gets up in the morning and says, I'm going to go to work and deliver biased care. And yet we know that caregivers are delivering biased care. That's how we're seeing the disparities in care. And for all that we are asking our caregivers do today, the technologies to support them and take some of that burden off so that their job can be sustainable hasn't been there. Now, generative AI changes that significantly, again, used deliberately and thoughtfully. So, for example, population health management has been a passion of mine for the last 2 decades. Back in the day when I did population health, we actually went down to medical records, requested charts. We got some medical students who were voluntold to carry the charts up to the office, and we would abstract. But fast forward to EHRs being implemented, and we would run reports, and then we'd have a set of care managers who would then go through and identify the high-risk patients and reach out to them individually to try to close care gaps. This is incredibly labor intensive at a time that those highly trained, dedicated caregivers are in high demand and short supply. So with ChatGPT, what we've been able to do is to actually pull together the individual's prior history, background, and in a very empathetic, and you've all seen the data on this, ChatGPT is actually more empathetic than some caregivers, maybe not, in an empathetic tone, tailored to who that patient is and what the details of their care are. Reach out to them and try to get behavioral change, try to get them to actually do something differently. Now, this is again where we have to be balanced about people having access to technology and email being the way that the modality by which they communicate. But if you can take some of that work off of our overburdened caregivers, it then gives them the ability to be able to focus more on those populations that need more support. So it's yet another use case for us to think about as we think about the ecosystem of healthcare. How can we unburden providers and caregivers so that we can spend more time and more resources on the patients who need it most?
So Nassim just brought back bad memories of the paper charts. So, I am now very appreciative. Even though I moaned and groaned about our EHR, that brought back really bad memories of, and just think of how difficult that was to get that data. You first of all, you got to remember which patient it was and all the, because there wasn't a really good indexing system. So that is something that is really, you look at what has happened over the last 20 years or a little more than 20 years, just the difference in our lives. But another thing she brought up was the burden, people, the physician burden. So, which leads to burnout. So, if people have total access to you, like the portal, so I use the portal as an example. Most people, whatever electronic health record, you have the portal. So, patients do have access to you, and they use the portal. But that is something, though, that you are on 24/7 now. You never get a break. And so they have total access to you. So that is one of the things you have to look at, because studies have shown that for every 8 hours of patient care that you do, you add another 5 hours of documenting from that. And that means using the from documenting in the medical record, that means doing referrals, that means having to answer patient messages through the portal or through our pharmacy. So all of that adds onto the burdensome. So that is why AI, for instance, can help in those situations, because it can kind of help you. You might be able to use the chat bot, or you might be able to use some type of step from that. So that will help you with that burden. So I was just saying, but she brought back memories. I was like, oh my gosh, I tried to put that deep, deep, deep in my head.
That's great. Let's look to the future for a moment, and let's stay on use cases and metaphor and examples. How can organizations stay proactive as they grow and adopt technology that promotes health equity for their patients?
Let me bring up something that Nassim hit on. Google research right now, they just did, it was released in January actually. So they did a study looking at, called Amy, using Amy. Just like we have Siri if you use iPhones. The Amy. So Amy stands for Artificial Intelligence Medical Explorer. So when you looked at what that did was they took Amy and they wanted to compare to see if you can do more advanced stuff like reasoning, diagnostic and reasoning, and conversations with patients. And so for those of you not in the medical work, and I'm in medical education, then one of the things is we have something called the OSCE. And so OSCE is when you use simulated patients for medical students, so that those students can, instead of practicing on real people yet, they can then use the simulated patients, which are actors, to give cases and for them to say this is how you speak to the person, this is how you come up with the treatment plan, this is how you do everything. So what they did was they used about 20 actors. They used about 149 different scenarios. They used specialists, primary care doctors, multiple, I think it was about 20 also. And then they did cases. And it was via chat, okay? So these were chats. So just like when you have a choice, do you want to wait for a human or a person on this line, or do you want to chat? So they used it as a chat. And they then compared as to how much of a difference there was. And surprisingly, the results of this was that the AI, Amy, she did better. And when you looked at empathy, when you looked at decision making, there wasn't a big difference here, but Amy did better with decision making. Amy did better with empathy, with the management plan. So they compared it in multiple areas. And so I look at that, and now this was done in the UK, Canada, and India. So I look at that, and it needs a lot more work, but it was just a step towards how can we train Amy, how do we, artificial intelligence, how can we train? And that's what it is. It's repetitive training, put the data sets in, all this stuff. How do we train so that we can come up with better outcomes, and also we can use it for training? So I'll use this as an example to say that there is the ability now to just really explode, because what we can't do is get that data. I might be doing up to date or Google searching or doing something else to get the data. Where you put the data in, they already have the data. So therefore, you can then, what I always say, just like Nasim, it's a tool. So I can use that, and what they compared was, if you looked at what does AI do? Data collection, wonderful. What do we as clinicians, what we are able to do? If you add the two together, which means assisted use of the artificial intelligence, then you come up with almost the near same amount of data. And plus you add what you go through years and years and years of medical school training to do. So basically, this was just my way of saying that this is something we use to augment and improve, but it's definitely a tool that will assist us, particularly as it grows.
Yeah, Michelle, you're highlighting something that I think is a critical trend in the future of healthcare, and that's the move to consumerism. So if you look at all the data that we now have out there and the ability to be able to access that data, we've really democratized that knowledge that used to be contained within organizations. And this has happened across the world and is now happening in healthcare. But if you look at banking, for example, remember the days where we had to go to a bank between the bank hours to actually open an account or deposit a check or be able to get cash? You now do all of that on your own time, right? There's the capability through technology to be able to do all of that on your own time. And that's happening in healthcare too, as we are seeing the ability for chatbots and other support services for people to really be able to pick and choose and leverage convenience, cost, access for what they need. And so I think it becomes really critical, but you're asking Matt about kind of, what should we think about as we're thinking about the future. We have to really think about how are we meeting our patients when and where they need us. How do we do that if they are at home, if they are at work, if it's at 2 in the morning, or it's at 8 a.m. that we are available and present for them to actually get their needs met. It's really interesting to me, again, when I was on the delivery side, and it was the start of the retail stores and pharmacy stores having clinics for urgent care visits. And I remember sitting in rooms in leadership circles where we said, well, none of our patients are going to go to a retail store or pharmacy store to be seen for an acute issue, because they are coming to a tertiary academic medical center to get care. They're not going to want to go to a retail store to get care. You know what? They did, because they were open at hours that we were not, because they were faster, they were more convenient, and they were more price sensitive. If we can't figure out how do we address the needs of the consumer, they are going to find a way to get better health and care. So that, to me, is a really critical trend that we have to think about.
So one of the things I like to do at the end of a panel before you get to Q&A, and I'm looking at all these faces in the audience, and I know we're going to have some great Q&A, is final takeaways. So we had some pre-calls, we've had a bright discussion today. How would you sum up your takes on health equity and value-based care into sort of a bite-sized note at the end of this conversation? And I'll start with you, Michelle. What's your final takeaway today for the audience?
So my final takeaway is that AI is a tool, is adjunctive therapy. And that with this tool, just like FDA has approved drugs, it has to be monitored and controlled. But it is a valuable tool that can be used to give people what they need in the amount that they need in order for them to achieve their optimum level of care.
Nasim.
Yeah, Matt, I've thought a lot about this as you challenged us with this, I don't know, more than a month ago when we first got together. And by the way, a shout out to Ben, who was part of all of those conversations, but unfortunately is recovering with a cold, so he could not join us here. But a lot of really great conversation around, what is really the takeaway when we think about tech's role in equity and value-based care. And I kind of have two. The first one is, and I've got two words. I'm going to say the first word is unacceptable, and unacceptable for the current state of how things are. Because I think, as we look across both the US and across the globe, it is absolutely unacceptable with the resources and the knowledge that we have today that so many people have to suffer and get inequitable care. And paired with that, because there are always these tensions in healthcare, is limitless opportunity. Because together, when we look at all these partnerships, hundreds of thousands of partnerships in this entire ecosystem of healthcare, we really have limitless opportunities for improvement. And so it really falls on all of us coming together, no matter what sector or industry you're a part of, to look at how do we leverage technology to be able to unlock those limitless opportunities.
Thank you to you both. So, adjunctive tool and unacceptability and unlocking possibilities. We'd love to take some questions for the two panelists today. Ask us anything. There's two microphones. Oh, excuse me. There's two microphones, or I think one microphone. So we'll take any questions from the audience. You can also use that QR code that's behind us and send one in.
I gotta tell you that the physician in me says don't use the QR code, stand up, get a couple of steps, and go to the microphone.
Yeah,
Yes.
it will.
Yeah,
Yeah,
we
we
can
can hear
hear
you.
you.
Yeah, yeah, go for it.
Thank you so much. That was really interesting. I'm Christina. I was really curious about you talking about democratized healthcare, because I think to me one of the biggest barriers to healthcare is actually just limited access to healthcare providers. So I think there was a statistic that said a lot of young people are turning to like TikTok as the first search instead of Google search. So in terms of thinking about algorithms, a lot of what these algorithms serve up in terms of healthcare is like inaccurate information, pseudo psychology, pseudo therapy, like all of this really like harmful, I guess, inaccurate health information that a lot of people just internalize as like that's their first access, that's the answer. So I would be really curious for your opinions onto what role social media should play into healthcare, and if you think that's being administered correctly, or like what big tech could do. Sorry, kind of rambling.
That is a great question, Christina. Thank you. Yeah, thank you for asking that. So, when I talk about democratization of data, that's exactly the use cases, which is you've got lots of data out there. Some of it is accurate and helpful, and actually a lot of it now by quantity is neither accurate nor helpful. In fact, it's harmful. So I know big technology companies are actively looking and screening out. I don't know about TikTok, but I know, for example, YouTube does this actively. They are leveraging algorithms to go through and screen out things that can actually be severely harmful. I also think, just like any other phase of evolution in human history, we have to educate ourselves and be proactive about this. So I've got younger kids, and in school, they're already being taught, how do you actually identify fake news? How do you actually look at the source of where your news comes from? And it was funny because like I looked up something on Google and my daughter was like, that's not a verified source. And I was like, whoa. So I think it's both. We both have to have responsibility as groups that host these platforms for things that can really harm people, and the consumer has to be more thoughtful in terms of what they're clicking on and what they're consuming. But really relevant question, I think that's gonna continue to be there for us.
Wonderful question. Next. Thank you.
Hi, I'm Maddie Heck. I co-founded a company that's developing a low-cost device for peripheral arterial disease screening. And so my question's for you, Dr. Nichols, going back to when you were talking about risk adjustment. So in 2024, CMS is phasing out the HCC codes for general vascular disease and leaving only the more severe form, vascular disease with complications. And that's phasing out over the next couple of years. How do you see this, or do you see this really impacting the ability to screen for PAD early? Because that's our goal, trying to catch it early and avoid those complications down the line.
Thank you. That's a great question. So, one of the things, and that's one of the things we have to monitor, because so often we have great programs, and whomever might be on either side of the table might look at phasing out various programs, because one of the things that you want to do is prevention. That's the key. The earlier you identify something, then then you have better outcomes. And so that is one of the things. That's why it's important to make sure that you monitor, you talk to your legislators and everyone to educate them, because one of the things you've said that is so unfortunate, and that's why you have to keep an eye, because so often the way we can all make sure that we get all on an even playing field is to make sure that we use tools for prevention. And going back to you, I think is a combination. Sometimes you have to use various social medias in order to get that point across. But I think that this is a great point. Where is it going to go? I don't know. I know that other people are saying this is not right. But one of the things that we really have to do is say that in order for us to advance, regardless if you're going to use some type of therapy such as AI, which I'm using as example here, or different type of systems that you use for remote monitoring or whatever, you still have to start early and prevent. Because again, that 20% that Yassine talked about, now you're going to deal with the 20%. And then you're talking about the cost of healthcare. Now you're talking about healthcare is going to be significantly higher because now you're dealing with the complications. So I think it's a great point. We just have to really keep fighting to make sure that they know that you can't phase things out because they're important.
Absolutely. Thank you so much.
Next. Thank you.
Hi, I'm Maggie. I'm a UX designer for Exact Sciences. I work on the provider portal right now, and one of the problems we're kind of seeing that's kind of relevant to what you were talking about with meeting the patients where they are, kind of helping with that level, that side of the equity, but also helping provider burnout and kind of setting boundaries in that space. Sometimes we see those needs conflicting. So like some of our tests are, they might receive like a positive breast cancer recurrence score or a Cologuard screening, and like they might get that at the middle of the night, but you know, we don't want them exactly having direct communication to providers. So we're kind of dealing with those two conflicting needs. Kind of how do you see like tech being involved in balancing those things so that we can kind of focus on both needs but also not contribute to provider burnout all the time by giving patients endless access? Have you seen anyone that does that really well, or any examples that come to mind?
So I want to clarify just to make sure I understand kind of where the tension there is. So you're saying if you're getting a result in the middle of the night, you don't want to push that to the provider?
Well, there's just the patient need of this is a very emotional experience. Like the next step is get in touch with your provider. But we also have on the provider experience side the overload, the
Got it.
burnout, the
Perfect.
constant
Thank you for
documentation.
that. Yeah. So I think that that's where, again, we have to leverage technology to reduce the burden on providers. So again, taking it back to what we were talking about with health equity and value-based care, we have a very large non-for-profit system that started doing screenings for social determinants of health, is now doing, and I'm looking at Danny, over 1,500 surveys per day on patients. They push that out to the patient portal for the patient to complete, and they're getting enough of those completed by the patients that it's reducing the burden, the administrative burden on the office. Similarly, with connecting people with community sources, they now through the portal have the ability for patients to actually look and self-refer for community resources, so you don't need to have providers do that. My point with those two concrete examples are, if we look at providers who are delivering care and actually reduce their burden, their documentation burden, their coding burden, so that they have time, I absolutely think it is the responsibility of a provider to be there for the patient when they are getting a positive Cologuard or a what looks like a malignant lesion. So I don't want to take away the human touch part. I think Michelle said this earlier, this concept of augmenting the provider.
Right.
So what can we take away with the technology? What can we augment in the workforce or automate so that the physician or the nurse doesn't have to deal with, so they can actually get back to what matters most, which is caring for the patient that's in front of them, so that they actually have time to address those, the human part
Yeah.
of care.
And I want to add on to that. So first of all, thank you for doing that. It's much appreciated. But something that can be done is, again, we're going to augment. And so one of the things, and let's say, because patients now do have access to their charts, their data, so they might be up at 3 a.m. and then they come across and see that, oh, my test came back positive. And so what do I do from here? So that's where you can send out something, a message. You can have it already for different, again, it's those algorithms, what can go out, with information, which with the note that the human touch. You have to add the human touch to say, this is, we understand that you have your results. This is what we understand it becomes upsetting. This is what the basic information. There will be a follow-up call by your healthcare provider in the morning.
Got it.
So what you can do is, again, is augment something that calms the person down to say, yes, we see it. So that might be where you have whatever pre-programmed to something that goes out, because you don't want to wait. So yes, that's better than the situation where the doctor might not respond to the person, particularly if it's a Friday evening and you now have to wait until Monday with really upsetting news. There's something that has gone up with the indication that now we are going to follow up. And it's like, I see you, I hear you, I understand what's going on. So if that can be something that can be done, put in on top of another layer, I think that that's where we are going. But I think that that's a wonderful thing, because burnout, it does get overwhelming. And so that's why there are now many young people that says, I don't know if I really want to go to this. I don't want to be on 24/7, 365 days out of the year. And we desperately still need providers. We must have, as Nassim said, that human touch is absolutely necessary. So that's the difference. Yes, you can have a robot, or you can have that a human that directs our technology on what it provides the best care for everyone. Great question.
Oh, thank you both.
Any other questions before we close today? This has been a bright discussion. Thank you both to Nassim and Michelle for joining. Yeah. So for now, this concludes our discussion about tech's role in health equity and value-based care. Thank you for joining us.
Thank you, everyone.
All. Thank you for coming.